There you go. Okay.
Okay, guys, please.
Now, when we first started using mini implants at the hospital, it was very good because it was good for patients who were medically compromised, where the physician wouldn't give you clearance to lay back a flap to put in standard implants. It was also good for another reason, that you only needed 4 millimeters of crest width to place a mini implant, whereas you needed at least 6 millimeters for a standard implant. And all our patients we treat with CAT scans, so we know exactly what kind of a crest we're dealing with. Now, the problem when we first put them in, there were two problems. When the residents would place them, they couldn't put them in straight. It's almost impossible to put in 4 implants, which they recommended, parallel and perpendicular. And with the implant itself, there's a metal housing. And if you didn't put the implants in fact, they had a brochure that they showed, and one of the fellows who was the originator of the housing, the problem was if you didn't put the implants in straight, you had to cut away the side of the metal housing to get them to fit. Well, if the purpose of the housing is for retention and you're cutting half of it away, you're defeating the purpose. So you not only need them parallel and perpendicular, but you need proper spacing. Now, the reason I got involved in this was because the Clark, who was the head of the company at the time, he was worried they were getting cases of paresthesia. And I said, when you use this system, it's impossible to get paresthesia because your distal implant's going to be 10 millimeters from the metal foramen. And the first thing I asked my residents, how far is the metal foramen from the midline? You all know? It's a standard measurement. Okay. To the foramen, to the metal foramen itself, it's 25 millimeters. The studies where they've worked with cadavers, they say 27 millimeters because the opening is 4 millimeters, so that the 27 millimeter is the center of the metal foramen. 60% of the time you have a 5 millimeter anterior loop, but if you're a centimeter from the metal foramen, there's no way you'll get a paresthesia. And even if it's a 2 millimeter implant, if you put it in the nerve, you'll have the paresthesia because the nerve isn't that wide at that point. Anyway, that's just some background minutia. Now, what you have to, if not that many of you have placed implants, so the first thing you have to consider is bone quality. And I think I'm going to skip over a lot of this because I think we've lost some of the time. But basically, the anterior mandible is a type 1 bone. Posterior, it's type 2, which is, type 1 is very dense. The reason you can get away with a very small implant in this area is because the bone is so dense, and the implant, when you're placing it, you're not drilling away bone. You're only making a starter hole to start the implant. Once the implant is being screwed in, it's actually compressing bone laterally for retention. You're not destroying bone. When you place a standard implant and you drill the osteotomy, you're going to get a dieback of bone for the first few weeks. It's a sigma curve, which I'm not going to go into here, but you don't get that with this because the implant itself is working like an osteotome. So I'm going to go through, and that's the different types of bone, from a type 1, type 2, 3, and 4, posterior. Now, what's interesting, in fact, I have to go back and show you this, because I always get a kick out of this. Oh, let it go backwards. Oh, it doesn't go backwards? All right, we're going to go over this very quickly. I can't see what's going on here. Here, how do you make it go backwards? What am I pushing the wrong button? You can't see it on the screen. Oh, now you got it. Thank you. Yeah, okay, go back to the first. All right, so that's it. Now, I want you to notice that this picture comes from Brandemark's textbook, which he published in 1985, okay? It's the standard book. He was the one that he was the one who discovered how to make an implant integrate. And I want you to notice who came up with the types of bone quality. Brandemark was an orthopedist in Gothenburg, and this is his classification system, okay? Now I'm going the wrong way. Okay, and the reason I want to bring that out is because I missed it again. I missed it. Here. Now you go from class 1, type 1, which is in the anterior mandible, type 2, which is cortical and trabecular, which is posterior, D3, which is the maxilla, D4, which is the posterior maxilla, and a D5 is added in an immature non-mineralized bone. And it now becomes the Mish bone density classification. So that's a good way to make your own classification system by adding something and not giving credit to Brandemark. However, what this is there was a time when it was thought that if you extract the tooth and you let the osteoid that fills in the socket, you could then remove this and place it in an area where you were drilling an osteotomy, and it would help speed up integration, and that's where that D5 came from. Anyway, that's something. So this just shows you how the bone resorbs. And this is the area where you want to place the implants, in this area between the mental foramen. I'm just going to go. Now, the thing I want to point out is that when the mandible resorbs after you've lost teeth, it's the labial plate that goes, so you wind up with an angle. And this is very important because when you place an implant vertically, it goes from the crest to the lingual plate, which gives you bicortical stabilization. I have diagrams of this later. But you see, the mandible itself is initially vertical. It's the labial plate that resorbs. And you can see how the angle changes. Initially, the angle from the incisal edge of the mandibular incisor to the cingulum of the maxillary incisor is, in 90% of the time, it's a 7-degree angle. Now, the people in Canada that came up with the overdenture system changed dentistry, so much so that Dennis Tarnow, who was at NYU until recently, started a thing that nobody goes through NYU with a complete denture. You have to have an implant-supported mandibular overdenture. And the implants were donated by Brandemark in their place, and the patients get them for free, and they get this overdenture. Now, and they place 2 implants, and they use a locking mechanism. They use locator caps for the locators to go on the standard implants. Now, I know some people don't realize it, but a standard implant that's 4 millimeters by 13, we'll say, if you place 2 of these, you have a certain